Panie Bartku, jest pan na wizji, na fonii.
Okay. We are about to finish the map. It's more quite detailed, and maybe we're talking about this correspondence of the voltage.
Bartek, ja tylko powiem, że drugi chairman, pan dr Marek Kiliszek, dotarł. So I'm giving him microphone.
Poproszę.
Cześć Bartku.
Cześć. Okay, so on the
can you play a little bit with CARTO values? Maybe if you will lower down to 0.2 or 0.1, we can check there is some kind of match, because here clearly this is a complete mismatch, but maybe this is just due to inappropriate CARTO value.
Okay, with the standard cutoff value, we can clearly see that there's no correspondence, especially in this area below left inferior pulmonary vein, and I've placed the catheter somewhere there now, ablation catheter, and I will move the pentaray there. So that was my first impression after these two so far incomplete maps, that there's a complete mismatch between these maps, and of course the study protocol is designed to ablate anatomically these areas and without any guidance of the potential. So despite the voltage above 0.5, we'll ablate it, but can we increase the 0.5 to 0.6 and then the upper, okay?
So our idea is maybe this scar is not transmural and it could be due to some epicardial scar. So if you can change it to a unipolar, so it will represent more epicardial surface.
What cutoff values do you use for the atrium for unipolar? Because it's
to be honest, I do not have any experience with a unipolar map.
Okay, let's play with the upper cutoff of the bipolar.
Are you going to isolate the veins also?
Yes.
Is it in the protocol that you isolate and ablate?
It is in the protocol. So I'll start with the isolation and then ablate these areas of the low voltage.
So, but well, anyway, can you just move it and check again? Is it any correspondence with this scar?
Wytnijmy pierścień, dobrze? Wytnijmy pierścień mitralny. We'll align the maps and then check again, okay? We'll play with the unipolar, bipolar.
Because I think that's for most people doing this ablation, that it's, well, the question which is most striking, I would say.
Okay. Okay, hide these points, surface points on this. Okay. And now try to move the image from the MRI. Do it in AP first. AP. Okay. No, without registration, just do it manually, okay? Okay. And now left lateral, please. Okay. Usually there's some problem with the angle of the both images, but here I think they're the same. Okay, right lateral. Okay, superior here, please. the inferior, and PA view. Okay. So, can we make it transparent? The MRI scan transparent? A little bit. Okay. And now please change to unipolar, okay, normal. And as we all do not have any experience, just make a 0.5 here and then move the upper limit. And then move the upper limit.
So set upper to 5 maybe.
Set to 5?
Nothing.
Usually 7 to the ventricle, so I'm not sure. Okay, hide the CT for a moment. The MRI for a moment. I'm not sure. So,
see, that's how science is burning. It's first time in Poland, I think, one of the first ever. And however, it's hard to see any correspondence. Well, that's well.
Make the map anatomical, okay? Okay, and show the MRI. Show the MRI. Okay, obrysuj, narysuj linię. Okay, I just go there to talk to the guy at the system just for a while, so I will disappear just for a moment. Jeszcze narysujmy tak. Nie wzdłuż tego złuknień. Wzdłuż włóknień, tak, przez to. Teraz przekręć trochę i tutaj też przesunąć jeszcze. Tutaj, po tej drugiej części zwłóknąć. Tu, od pierścienia do żyły. Nie, nową. Dobra.
To jest bardzo ciężko.
To nie. Tutaj. Dobra, okej. I teraz AP. No. I tutaj też wokół tego. Wyżej. Nie, stąd, od pierścienia. Od pierścienia dookoła tej białej plamy.
I think it's good to see the outcomes in a multi-center study, because we know that in a single center, from the single center experience, the outcomes are always better, much better. But when you compare to the multi-center studies, usually the outcomes are different.
Ile jest centrów w tym badaniu? 20, nie?
Ok, schowajmy widok rezonansu. PA poproszę. A kreski mamy narysowane na tamtym? O nie. Okej. No i na drugiej stronie jeszcze. No. Correct, please. I have two concerns here about these regions of the fibrosis. First of all is left atrial appendage. Isolation of the appendage will turn off its mechanical function, and it may result in thrombus formation. So I'm not sure Is it a good idea to do it in the first procedure? And the second area is on the septal part of the anterior septum. So we can expect some structures of the conduction system there. So it's another obstacle maybe for isolate this area, of course. So probably I will abandon isolation of the appendage and keep caution on this anterior, on the septal part, because just to avoid some complication. Okay.
You know, my experience is that it's not easy to isolate left atrial appendage. If you really want to isolate appendage, I think you can fail. However, if you don't want to isolate, it can happen.
Okay, so I will normally start. I do not make some circumferential lesion around this area below the left inferior pulmonary vein, but isolate the vein separately and then make some additional lesion to isolate this region below left inferior vein. Of course, targeting this area, I will probably have to ablate mitral isthmus just to prevent perimetral flutter in this case. So maybe it will require burning in the coronary synods. We'll see. But I will connect this point of the circumferential and isolation to the line of this design line of this fibrotic area. I'm using ablation index as well for this procedure, just to optimize the ablation. Możemy podgolić trochę powierzchnię. W porządku jest panem? Tak nie reaguje?
So are you using 400 at the posterior wall and 550 at anterior?
350 usually, because I use a higher power but shorter application. So
you use 40 watts?
Yes.
Okay.
For posterior and for anterior 45 for anterior wall. But basing the lesion formation and ablation index seems to be very safe because you can control the lesion formation.
We know from the animal model that 350 is the minimum value of ablation index that gives you a permanent isolation.
Idziemy z elektrodą. To avoid another burns on the posterior wall, I will incorporate this area into isolated area of left veins.
So could you just tell what you are going to do step by step now? I mean, what is strategy or plan as usual?
First of all, I will isolate the left veins and probably then go for this area of fibrotic tissue below left veins. Just to do it at once, because I think that waiting too much will maybe create some edema or something like this, and it will be difficult to close the gaps between this first circle and the lines to mitral isthmus. Then I will go for right veins and then for this septal part.
And do you want to eliminate this fibrotic area with a encircling isolation, yes, or just homogenization?
I will usually try to encircle the area.
And your endpoint is, I guess, no potentials inside and no capture with a maximal output. Capture. Okay, right. That's good. But sometimes it's really hard to achieve this. So yes, if not, I think homogenization is the only issue following this.
I use the steerable sheath on a regular basis for this procedure because deploying lines is sometimes quite tricky and difficult. So the stability and energy delivery to one spot is very important to create a good line.
Yeah, I think it's really helpful if you have a large atrium, like in this case. However, it looks maybe not extremely enlarged, but when you have a persistent, you expect that the left atrium will be larger, and then I think using a steerable sheath is a good point.
Jak się gain trochę większy na PV?
Well, one parameter which could be measured to assess this fibrosis would be a measure impedance. Okay, well, maybe we'll look at this as well. Is it any difference between this fibrotic or not fibrotic tissue?
Dobrze, pójdziemy sobie od dołu, dobra? Czy wrócimy do tego pierwszego punktu? Okay. So the part of the procedure is the standard PV isolation. So it's, pokaż troszkę przodu teraz. Zrób prawą też anatomiczną teraz. Okay. Pokaż trochę z przodu teraz ten widok. Dobra. Mamy dwa podobne. This part may be a little bit more difficult as usual. Okay. 45 W poproszę. Usually increase the power on the anterior aspect of the veins. Podgolimy trochę. Wyłącz to pomarańczowe coś, po prostu. O, okej, dobra. Okej. Troszkę z przodu, pokaż z przodu teraz ten widok. Okej. Jeszcze bardziej. Drugi żyła w osi, poproszę. Dobrze, jeszcze, dobra. The most tricky part.
The procedure is performed under general anesthesia.
Yeah, have this comfort today. Just to not concentrate on some.
Yeah, because we can see that the patient is not moving. The respiration is really fixed. So you can achieve a really good stability with your catheter, and there's no movement of the patient due to pain that you usually have when ablating around the inferior veins when the procedure is being performed under conscious sedation.
I think there are only two centers in Poland that are doing it on maybe only one center doing these ablations on a regular basis with general anesthesia. So we know the everyday problems, right?
There is a paper on this in a Europace, I think, and they clearly prove that the procedure is, shorter, more comfortable for patient and doctor, and probably they prove that it's more efficient whilst performing under GA, not a conscious sedation, but.
Okay, it was a request for a foreign guest to have general anesthesia. So Bartek took advantage of this.
We have already isolated the veins, but of course I will complete the line. And you can see there's some activity in this vein, probably due to RF delivery, but we'll watch on this.
Yeah, there is a clear dissociated potential, so probably the upper vein is isolated.
Lower.
But anyway, you need to keep ablating.
Right. Do you have the same observation? The first pass isolation is very often using this technique with ablation index. It's like I would say 75% of the veins are isolated with only one encircling without any additional focal touch-ups of the RF.
Yes, I agree.
Okay. Troszeczkę w lewo. Lewo, 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 lewo.
I think the frequency of firing within this vein is quite frequent. So maybe it was just a, PV dependent AF, and maybe this vein was just maintaining the AF. And that is why some previous DC cardioversions were ineffective.
Zamkniemy jeszcze górę, dobra? Ok, od góry trochę, bo tam idzie... jeszcze od góry. Jeszcze. Co bardziej przód od przodu, dobra? Góra i przód. Tutaj prawy w osi idzie zawsze żyła. Ok, dobra, a tutaj od góry. Przód najpierw, przód. Dobra. Probably the lower arm is isolated as well. So it looks like.
Do you check pacing?
Yes, but just afterwards. Sometimes that there's an edema of this ostium, and the signals are very, very tiny. And pacing reveals conduction, so it does not happen often.
But the stability of the catheter is really impressive.
That's why I use for this complex procedure steerable sheet all the time, every time. So it's an additional cost, but I think it's really ablating the lower aspect of the inferior veins in larger atria or deploying lines. It's really, really difficult. Okay. Z przodu. Okay. There's some rule to keep the force above 10 grams. Do you think that using these formulas, calculating the lesion formation, is it necessary, or are you happy with 5, or maybe, or even less sometimes? Of course, it depends on the anatomy. Sometimes you cannot get more than 5-6 grams, right? But
I accept 5. I'm always trying to have around 10 or more, but sometimes, as you said, you are not able to achieve more than 5. So just you ablate longer, and that's all. It's good to have an ablation index because then you just ablate longer and you create the same, lesion value. And we presume that it's okay. However, we do not know.
Not quite sure. But still, sometimes there are some places where either you have stability or you have good contact. So you have to choose. There are some regions in the left atrium. So then I choose to have less contact.
Better contact. I would choose stability.
I choose. I choose stability, of course.
Right. Is there any gap still? Okay. And up there, right? Przejdziemy na tę linię, to zmniejszymy do 400 W, dobrze? Tu jeszcze dwie aplikacje. Tak? Okay, and the last one. Okay, zmniejszmy do, let's see. You have kind of gap police again. Cannot leave anything. Okay. 40 poproszę.
So maybe check the left lower vein if it's isolated.
It is,
Just
it
pace
is already
maybe.
lower. Yes.
So maybe just pace and we'll have completed.
Okay. Proszę stymulację z Pentareya. Or do you want from the...
I prefer if you could perform it from ablation because you can control the force.
As you wish.
No capture, good.
Stymulujemy. Zrób tak, przytnij ten przedsionek, żeby było widać kulki, dobrze? Na powierzchni. Tak. I za każdym razem, jak robimy to... Pokaż z przodu teraz. Poczekaj, to skończmy stymulację. Okay, we go around. Okay.
Clearly no capture, so it's isolated.
Right. Okay, so stop pacing. Poproszę, żebyś... O właśnie, pokazał to wszystko. This shaving tool is really nice, and I like it very much. Okay, thanks. PA poproszę. Okej, dobra, PA. 40 jest, tak? Tak. Pokaż na chwilę MRI, na sekundę. Okay.
So now you're operating in a posterior mitral isthmus area,
Right.
and it's quite thick tissue. And we know from a Deutsche study that just using 550, blinded to the operator, they were not able to achieve isolation. So sometimes it's really hard to...
But at this left inferior vein, sometimes you can push against the esophagus here. So I will use higher values of ablation index when I'm closer to annulus, because here I'm a little bit afraid of extensive ablation in this area.
My personal experience is that in 90% anyway, you need to ablate epicardially from coronary sinus.
Probably in this case will require burning in the coronary sinus.
Hopefully it's not this case. It will be nice to see isolation without this.
Golimy troszkę. I troszkę w dół. Idziemy. Okej. Dobrze. Wrzućmy na chwilę rezonans. So as I told you before, I'm just checking the MRI shell, just to ensure that the line is correct. Because while you shave off the surface, this line moves a little bit, so I'd like to be sure that I'm on the right way.
You know, my personal impression is that if you have a true fibrotic area, it's quite easy to isolate. And if it's just healthy tissue, you have more problems with this. So if you are able to isolate this area quickly, it might mean that it was, you know, not healthy.
Truly fibrotic.
Mm-hmm.
Not. Zróbcie clipping na PV, dobra? Nie widzę ablacyjnego sygnału.
Can we switch to this resonance image? It's
Wrzuć mapkę z rezonansu. Włączcie stymulację z PV od wszystko jedno, który będzie brał, tak? Jakiś, ile mamy cykl? 900. 700. We'll start placing from the appendage. Just to check the conduction. But this may be the case that I will isolate the isthmus a little bit higher, in the upper part, and then just connect along the coronary sinus. That's the other.
So now we just expect just shifting, CS from concentric to eccentric, yeah. So then it means that the isthmus is isolated.
Proszę na chwilkę rezonans wrócić. Proszę.
Ciekawe, well, it would be interesting to make this burn and pace technique as Chris Piórkowski showed last year. So we will be sure about transmurality then.
Okej, wymieniona są, możecie zrestartować. Dzięki. Okay. So now it's the annular part. Looking at this ablation signal. A ile było? Okay.
probably there is some change in activation because distal and proximal CS are on time, or nearly on time, so it means something happened. So, but the isthmus is not isolated yet.
Conduction is slowed down, but still needs some work. I will go for this upper line first, and then check if I'm able to isolate there, and maybe go along the mitral annulus. It has to be blocked somewhere, but not particularly in this spot. The more proximal to the CS, the more difficult ablation of the mitral isthmus. So. Okej, przejdźmy na tej linii tutaj teraz. Dzięki.
I think it's good to say how you defined the mitral annulus. And here, what was really good, that you were ablating until the ventricular signal was much larger than atrial. So you do not stop when you have a mitral annulus that was delineated by MRI or just by reconstruction. It is really important, yeah.
After all the time, no, still electrophysiology, not anatomy only, right? So we have
a little bit more.
By the way, can we see the MRI image for a while?
Rzuć na chwilę rezonans.
A little bit longer. Why don't it disappear that fast? I don't know. Okay.
Dobrze, wyrzućmy to na razie.
So what will be your strategy if this area is not isolated?
First of all, I'll try to search the gap for it just by pacing in different spot and checking S to CS time, and then try to ablate a little bit inside along the line.
Because
it happened that I had to cover the whole area, but of course I do not believe that the homogenization is a good point here, because it will probably during healing it will create some I don't know, healthy tissue between the clear isolation is for me is the best way to achieve just to turn off this area. But of course, if it doesn't work, I will have to cover the area with the ablation spots and then check for viability with pacing. But I do not truly believe that it's really good point when you surround the area and it's silent. I believe that it's really silent and completely ablated, but when it's only ablated from the inside and spot by spot, probably during healing some viable tissue will remain and maybe substrate for the secondary arrhythmias.
I do agree with this, but finding the gap I think is good just to perform so-called pace and ablate, so we just pace along the line and find the places where there's a capture, then we ablate until there's no capture. This is, I think, the one way of doing this. And the other one, I think that is also helpful, or might be helpful. You just pace from the ablation catheter inside the box.
No, sorry, it's not a block. I thought it's just chained for a while.
Mm-hmm.
No.
And just find a gap with a activation map from a pentaray catheter. It could be also nice.
That's a good point.
So maybe you can use both.
And what's exactly in the protocol? So what are you supposed to do according to protocol?
To turn off these areas,
Is it written how you should validate
lack
it?
of capture.
Lack of capture, okay.
Yes, lack of capture.
Yeah, to be honest, on CS it looks much more concentric than before. So for me it's clear that CS12 is later than CS910, so probably it could be isolated.
But still we can see some clear signals in this area, so probably even if it's isolates only from one side, will probably connect along the annulus.
So the mitral isthmus was not isolated with the first line. So you need to pace and ablate along this line. Maybe this line what they are actually creating, it's okay.
Co? Dobrze, to tylko czas niech, tak? Czas. Rzućcie to na review, proszę. This area is later than the CS12 inside, so probably there's no, it's not isolated here with this first line. So now I will try to just connect this line along the mitral annulus. It's probably conduction is the annular part.
Do you have in the protocol any inducibility at the end of the procedure or not?
No. The protocol does not require induction.
Because usually operators that are doing something more than just pulmonary vein isolation, usually they are trying to induce, just to see if they not created some.
Mainly for ATs, right? For
yes, of course. But still, it is very strange that such healthy-looking tissue is marked as a scar on the magnetic resonance imaging. There's something with that. I think with the magnetic resonance, not with the potentials that you record. Some tests are with error.
Yes, that's true. One of them has to be mistaken, obviously.
Maybe this area is only mildly affected. It could be an explanation.
But the green color indicates that the larger volume of fibrous tissue in this area. So,
can you see online again ECG?
ECG?
Yeah, just.
Okay, poproszę także. This region is clearly not isolated, so poproszę wyzwolony ekran. Trigger zróbcie. Mhm, 200. Możemy ten ekran, okej, dobra, widzicie go. Okej, postaw kreskę na ablacyjnej dystalnej teraz. Ale nie pilnuj jej, tylko po prostu postaw na razie i trzymaj w miejscu.
So you want to find the earliest activation?
Yeah, it's somewhere here, the annular part. So that was... But it's here, at this line, so this line is not blocked. Okay. Pokaż bardziej w kierunku, którym celnik. Okay. It's not going to be easy, I think, here.
It's MRI-based case, persistent atrial fibrillation. And Bartek, could you show the MRI screen?
Prosimy rezonans. Już?
It came from Utah. Bartek, Chris Pierkowski just arrived and I'm trying to I'm explaining him what you are doing, but maybe you can tell it yourself. It will be well. Could you just tell what it's briefly what you have done until now?
Okay, poprosimy rezonans MRI. Okay, hello Chris.
Hello.
Hi, how was your trip from Berlin?
It was good.
Right. Okay. So we have MRI guided ablation, and you can see the shell of the MRI with the fibrotic area marked with the white and green. And after isolating of the left veins and trying to ablate this area involving mitral isthmus, but it just created those lines, but it doesn't work for now. And so I'm trying more ablation at the mitral annulus, and the next step will be to go epicardially and then try to block the mitral isthmus from the outside.
May I ask a question?
Right. Yeah.
Before you ablated there in this presumably fibrotic areas, what was the local potential looking like there?
Local potential is quite normal.
Okay. I'm just curious. I'm not judging. I'm just curious.
Yeah, just show the voltage map, please.
This was the major question of everyone. There's complete mismatch of these fibrotic areas.
Okay.
So, as you can see, it looks like completely healthy tissue.
Then it will be hard for you to block it. Huh?
All right. I know. I know. Okay.
But don't give up.
Of course not. And I have to be honest. In my department, we're also working increasingly with substrate imaging based on MRIs. We have installed our own MR scanner and scan every AF patient. And I think what is crucial is the question how the post-processing is being done, the segmentation of the diseased tissue areas. And there are different approaches, of course, and therefore I was curious what the Utah scan showed you.
But unfortunately, the Utah Center does not share with their approach, so you do not know how they are doing this.
What we use for segmentation is the Galgo software from Barcelona, and that we can also do in-house. We don't have to send it away.
And do you have what's correlation between the signal And what you see in your MRI?
Yeah, that we do see correlations. We're still trying to fine tune the segmentation thresholds to get a really 100% match. But
I think I will go for the coronary sinus now.
the match is good. If the MRI says there's something, there's something. If the MRI says there's nothing, there's nothing. On the voltage map.
Okay. Okay.
To nie dobieramy nic, nie?
So this is okay. So this.
Probably I'll have to go out with the CS catheter
Okay.
and then try again.
It's a redo case
Get
for
there.
the line here, which is here. And you see here's nothing behind the line. It's also okay. Here's this so here. Fits quite well.
Yeah. It's one of the very first cases, so we cannot say relative.
One has to get experience.
So, but it looks very nice.
But I've heard this before. That's why, but it's the first time I see it. Yeah.
And what is cut off for your signal here?
0.5.
0.5.
But we're still trying to. Sometimes the dimensions do not fit. So this is smaller than this or vice versa. So we still try to find the optimal segmentation.
We need to little bit more play with this. But you have also this circumferential, well, this border, this line on the border on the scar tissue, and just. Do you have homogenization? What's the approach for this? Yeah.
So here we would take it out and take off this guy.
Okay.
Yeah, well, we try and sense, but it's not always possible when we do it live. But in my experience, it doesn't make so much of a difference for the image quality if it's not really rapid. And we do this in-house. We don't send it away. We have a workstation for the segmentation in our MRI. And let someone give it to you.
Pokaż mi na tą okolicę teraz. 25 mamy, tak? It's really hard to keep the stable position in the coronary sinus here. The ostium has quite difficult angle.
It's just the different colors. Scar, here. See?
Yeah, yeah. That's good. curious what will happen. And,
Zatrzymaj stymulację na razie.
so, just looking
No trochę od dołu, tam widok. Okej.
So Bartek, what are you going to do now? Go to coronary sinus or?
Yes, I'm trying to find a stable position there, but it's okay. There's somewhere there.
It's hard to isolate this.
And I would like to. Okay, there we are. I'd like to introduce the CS catheter as well, just to monitor the effect during ablation. Okay. It's really hard to make a pressure against the wall here, not against the free wall of the CS. Stymulację proszę. Okay, so that's the main problem here. That
Can we see the X-ray?
Okay.
Maybe you can try to advance when you're in the CS with the ablation catheter, advance the sheath deeper into the CS to support your catheter better. And now the sheath.
Right.
More, really, into the CS. Yeah, more.
Even more.
Even more, up to 5 o'clock. And then you turn the sheath that it points upwards.
I don't have enough courage, I think.
Trust me, nothing is going to happen.
It will go out. It will go out.
Turn the sheath as if it would be a CS catheter. Twist it. Yep, yep, yep. And now the catheter alone. Keep the sheath twisted. Keep it
try.
Twist it upwards. Upwards.
Okay.
I see the problem that you have to get good contact in this region.
There's some branching here as well. So.
Yeah. What I always do when I'm having these issues, and this is not so uncommon, I also yeah, very good. And now it's supported with a sheath. I also try an RAO projection that sometimes I find helpful. Look, now you have a good position.
Okay.
And if you want to monitor instantaneously, maybe you can even put the CS catheter into the left atrium underneath the line. And then you have the pentary and the CS, and then you can stimulate and look while you ablate. Just a suggestion.
See if it's possible to get here. What? The angulation of the CS is really here. Okay. Try to go again with this ablation. No.
Where do you pace now from?
From the appendage.
From appendage. Do we see the CS1-2 signal somewhere?
CS1 too?
Yeah, it's underneath the line. Yeah, it's still short, yeah.
Yeah. Jaki macie stymulacji prąd na tym? Przerusz na prawo.
You still have big potentials on the ablation catheter. Huh? Not here, but a little bit before.
No na prawo. Fortunately, they're not later than CS. Teraz daj na prawo teraz. Teraz, przerzuć.
Look there, they're sharp, big, and why don't you play there? A little bit backwards. They were so sharp and big.
Just a moment.
No, more to the annulus. There, look there. You saw the signal there?
Yes. Right. Just.
Also there, it's early, it's so early.
It doesn't want to block, unfortunately.
It's a dick.
So I'll try to close this area a little bit far from the annulus. To trzymaj stymulację na razie.
Maybe let's come back to the left atrium and just pace and ablate along the line.
Or just ablate the whole area and that's all. What do you think?
I think the idea to map in the left atrium is a good idea.
But do you prefer just pace and ablate, or just maybe to pace within the box and check the gap with a pulmonary catheter?
I would really look for differential pacing. Means I would either pace from CS12 or from the pantry, and then look for the shortest conduction. I would really try to block it.
It's even hard to get the standard CS catheter. Okay. Proszę stymulację moment. Jeszcze nie. Teraz stymulacja z pentareja. I trigger, proszę.
Can you show us the signals, Bartek?
I pokażcie ten na 200. It's late here and getting earlier and earlier. Well, almost no signals here, but
Can you bring the CS catheter deeper in?
no, let's go now. One moment.
Yeah. Keep it that way. Just hold it and look for the signals. Yeah, it's propagating from 1-2 to 5-6.
Right.
Yeah, so I would go opposite to 1-2 from the inside and burn there. It's the shortest that you have, CS12.
Mam 45 zrobimy.
Can you reach a little bit more to the annulus, where you have a little bit of ventricle on the ablation catheter? Yeah, there. And go then slowly upwards along the annulus. And can you ask the CARTO engineer to store the position of the CS catheter in the map as a shadow?
Zrób cień CS-u.
Because when you will not block it from the inside, then you just go again outside to the shadow position CS12. There's no signal on the ablation because there's really...
It's ablated from inside.
Can you map a little bit more to the atrium there? What you will see?
Almost nothing here.
A little bit more? More to the atrium, more to the atrium. More.
Pokaż mi końcówkę elektrody.
Look, it's late here. It's late. It's later than CS1 too.
Right.
So the gap is epicardial. It's no doubt.
Yeah.
You have to go back into the CS. I'm sorry.
Or maybe you just isolate, the right veins, and then you go back to this part. Think about it. Or you just place this triangle area with the ablation spots.
Just around, just turn off this area, and then maybe at the end try again block it for some application. But I don't want to burn it extensively here. So probably I'll close this triangle a little bit more at the atrial side, and then go for right veins for the septal part. And PA mi pokaż. PA. I teraz przekręć od dołu i troszkę golimy, tak?
This area looks quite silent. No atrial potential on ablation catheter. Maybe you can pace from inside.
It's dead.
No, it's probably now it's isolated. Z ablacyjnie poprosimy stymulację. Okay. Looks like this part is okay.
Yeah, no capture. So you can see that this area is isolated. However, the mitral isthmus is not isolated.
It's not blood.
So it's just epicardial problem.
But I think you reached the point of the study.
For this area, yes, but the study protocol says that when there's some short distance to some anatomical structure, it is advised to block it. Yes, like it's
so here clearly the problem is on the epicardial side, not endocardial.
As I said before, I don't want to burn extensively there, so I will go for right veins and then try again at the end to block it, but stop stymulacja. Pokaż z przodu i prawą dolną. Bardziej w miejscu, gdzie jestem.
Sometimes the fibers in the CS that still conduct are on the outer layer of the CS. That means
since I was trying to move around, but you know, with this angulation, it's really hard to, and I usually turn around the catheter when ablating in the coronary sinus, but in this case, it was quite difficult.
We appreciate your efforts.
So normally, if you know, I have a perimitral flutter, so I always use anterior mitral line, or if I want a posterior mitral line first, I try to get to the CS, and if I know that it could be a problem, I do not ablate there. But of course, this is a different issue.
Z przodu możemy. Mhm. Troszkę od dołu bardziej, wiesz, żebym widział relację między tymi... O właśnie. Poproszę na chwilkę. Okej, dobra, dzięki. Za pół godziny miałem. Daj tysiaka. Do góry bardziej, idziemy. Dobra. Też bardziej w kierunku, którym ciśnie. Tak. O właśnie, okej.
goes through until the sedation, deep sedation is
Dobra.
stability is really great. This lunch is since 10 minutes. If you want to eat something, it's
W górę. Jak będzie, tak? Mhm.
So may I ask my co-chairman what they do in a persistent atrial fibrillation? What is the approach of Radio Center?
So my personal approach is first to isolate the veins with WACA, then cardivert the patient, check if there's any low voltage areas, and then ablate those areas. But it depends if this is just less than 30% of the atrium. We ablate these areas just trying to encircle the low voltage tissue. But if this is extremely fibrotic, I just isolate posterior wall, sometimes mitral isthmus, and that's all. And sometimes you have such cases that you are trying to cardivert the patient following PVI, and the cardioversion fails, or the patient, the atrial fibrillation is coming back. So at that time, I'm trying to ablate cafes, because you need to do something if you have a patient.
Whatever it means.
Sometimes it's really effective. It depends on patient.
I usually do just pulmonary vein isolation, and I try to look at the potentials during atrial fibrillation. So I try to see low voltage areas or high voltage areas during atrial fibrillation and see whether we can do something. And I even try to repeat the technique of mapping atrial fibrillation with a pentaray, just to find, areas of spatiotemporal dispersion or something like that. But I think it's too much of ablation as for first time ablation, so I quit this, and I again went back to just pure pulmonary vein isolation. And if I see something that is really, it looks clearly like low voltage areas, sometimes I ablate it.
Oh, well, so far I think it's no scientific evidence that anything more than PVI really brings the benefit, which is okay. Therefore, the study is performed.
We do not have any uniform approach, so we can do anything we want, to be honest, because I think every single strategy could be effective. So we need to compare this. So that's why it's good to see this.
Well, that's problem. On the other hand, it's to do not harm patient. do not be pro-arrhythmic or this, because extension of lesion always brings this danger. However, the follow-up of the patient which were already done, it's good. They had no recurrences, and I was surprised because it were not easy cases. As you saw, this extent of fibrosis was quite big in the previous one.
So we exactly know that the patients without fibrotic areas are doing better than those with fibrotic areas. And the problem is what to do with this patient. I know that in some centers they are trying to prove that those areas are responsible for non-PV firing with the isoprenolol challenge. And if so, they isolate it at that time. I think that anyway it's good to ablate as less as possible.
Well, when Chris will be back, we have to ask him, because he was famous to make those boxes. And we will see a result of one of the patients from the last session. It was also not bad, so maybe.
I think that what is really important is just to use a so-called tailored approach. So we tailor ablation strategy to the patient. If there's no low voltage potentials, maybe just PVI is enough. If you have some low voltage areas, maybe ablate this. And if it's extremely diseased atrium, do some box procedure. However, we need multi-center randomized studies to prove this. Until we do not have evidence-based medicine that something is better than other, it's a matter of debate.
Of course, I agree. So, but you don't have this Dach lesion or any others which is some sense does this on a regular basis. I even remember 10 years ago we made mitral valve lesion and one on the roof, which was supposed to add some benefit in all patients. But I don't think anybody still does it. Or do you know any centers in Poland who makes this? No.
I don't think so. There's also a problem that those procedures are time-consuming, and it also matters, especially that you have such alternative like a cryoballoon ablation that is less time-consuming. So.
Well, to be honest, it's interesting. I talked with Marush, and he said it's also possible to do it with balloon. And he promised to send me a presentation on it, but it never happened. Mm-hmm. But it's what he says.
Mm-hmm. I think it is possible. There was a paper also in Europace that they were trying to isolate a posterior wall with a cryoballoon, and it is possible just to change the rotation and just to put the balloon against the posterior wall, and it was isolated. But I do not have any experience with this, and I don't know if it's easy to isolate the posterior wall with cryoballoon. It seems to me that it's not so easy. Maybe that is always like that. In a single center experience is much better than the multi-center experience. That you can't replicate this method. So maybe just one or two experienced operators are able to do this, but not every single operator. there is also, the matter of debate, how wide you need to ablate in terms of achieve pulmonary vein isolation. We had a discussion just a moment ago because, there is also no agreement, how large is enough. If you need to be really ostial or maybe just to create these circles that will meet just in the middle of the posterior wall, it is not well established. We can presume that, the more antral you are, you cover more these, areas of these leaves that could be the foci of firing, ablate some ganglionated plexi. Maybe it's a little bit better, so we do not know.
I have some impressions from reduce after cryoballoon. When sometimes with the balloon you cannot tailor the procedure for the particular anatomy. So sometimes the AF recurs despite the distal isolation of the pulmonary veins, and then the extension to of the area to the anthrax may help. Do you have the same observations? So, it's...
if I perform a radio ablation of the cryoballoon, that I was the first primary operator, so my experience is that sometimes the anatomical map looks, like a disaster, like, a grenade just detonated inside. Because, when you use a different angle just to have a good occlusion of the vein, I think that you can touch anterior wall, posterior wall, and you can have a problem with this, and sometimes it looks really great. But especially in terms of a left common pulmonary vein, when you ablate with a cryoballoon, you ablate really ostial, and you can leave just this tissue that could be, the foci of firing, and you are not able to ablate this with a cryoballoon.
It's isolated.
Nice.
Can we have for a while also this MRI map to recall how it looked?
You do. Okay. I will just finish this line and then. To już, ale bardzo się kończy.
Co się kończy?
Sól do chłodzenia.
To jeszcze jest jakaś.
Już. Okej, możemy MRI poprosić? Okay, zróbmy naszą mapę trochę transparentną, prawda?
Okay, so
45, proszę. A zróbmy troszkę mniej transparentną tą mapę. Okay. It's going to be hard to assess the line between the or completion of the line around this area. I don't want to ablate at the lower part of this area too much at the annular part, just to be safe and not to do any harm to conduction system. Right?
I don't think you have a risk of damage of conduction system. Bachmann's bundle maybe, that's all.
Bachmann's probably it's a little bit
It's higher up.
the posterior, right? Here. I had one case of atrial tachycardia from the left-sided septum recently, and just immediately after terminated, the catheter removed in this area, and this was a 2-to-1 block. So I'm not sure it's not possible here. So after the tachycardia termination, it was some moment that heart stops and the catheter dislodged just for a while, and was enough to
But to be honest, I haven't seen his potential on this side. So, when you're in the left ventricle, transaortic or just you deep inside, it is possible.
Yeah.
But at the atrial side, I do not have such experience, to be honest.
But still someone who keep an eye on the rhythm and looks for some
Of course.
novel activation is necessary, I think.
Also, ablating at this area, if there is, slow or fast pathway located on the left side, you should see junctional beats or something like that. But I haven't seen any.
So I'll ask someone now, just for a while, just to keep an eye out for the junctionals here.
Okay, dissociated potentials within the right upper vein. So left upper was arrhythmogenic and right upper is also arrhythmogenic. However, the frequency is much lower than in left upper. So PVI here is, I think, really beneficial, crucial.
What would you do if the, mitral isthmus wasn't blocked after this procedure, and they had recurrence of the left-sided flutter, mitral isthmus related? Would you go again for it, or just complete the anterior line?
I will complete the anterior line, to be honest.
Right.
And here, I think that, because we have a clear slowing down the conduction through the mitral isthmus, so if you are not able to achieve the line of block in the posterior lateral line, here I will perform a full antral line. Just to prevent, because I think the possibility just to have a perimitral flutter when the conduction is much slower than normal is quite high. So maybe just not, keep ablating with NCS, just extend the line to the right upper vein, the right waka. Just a suggestion. Nothing obligatory, of course.
Proszę, Mraj na chwilkę.
Well, I just want to say that we're going to continue according to schedule. So, well, it's now we have lunch break. If somebody wants to eat, that's well opportunity to do so, and come back because I think we will go non-stop with this case, and then we'll start another one on another room as it is written in program. So just that you know. Ale światło to wyłączmy jednak.
So Bartek, keep ablating and I will eat something.
Okay. Enjoy your meal. I have to enjoy mine a little bit later. Zerkajcie tam, czy jakieś węzły się nie sypią, dobra?
We talked that we will start the next case according to the schedule with conscious sedation because that's issue. But well, we may continue it as long as necessary. So we have very exclusive. No, Chris just came back from lunch, well, late lunch, and then some. Most people are just on the lunch. So we have a very exclusive society, just like.
Okay.
And it is not. It is fourth, I think, or third. I don't remember exactly. But the question is, how many decaf cases?
Fourth?
Fourth. Yeah, it is.
Fourth with fibrosis, but some patients were aligned to the standard PVI, right? So it's probably 6th, 7th, or 8th case in the study. Stymulacje zablacyjne, proszę. Stop. Stop.
Yeah, but well, all cases were like 3 hours, I think, or more.
So Bartek is too slow.
No, Bartek, it's very good. It's and it's
Bartek?
Yeah.
Angie says you need to work faster.
More? Even more? No.
Yeah. Faster and more.
Faster and more. Trying to do my best.
No, well, we are very impressed, but the lines are perfect, and well, stability of catheter, it's really very, very impressive. And Chris, do you like this image? It's really perfect, don't you think?
It has an artistic.
Yeah. So we don't complain for anything. It's only. Could you show us this MRI for a while? Just
Rezonans. Możemy troszkę mapkę transparentną zrobić, żeby było widać lepiej rezonans. A weź rezonans nietransparentny w tym układzie. Stymulacja, proszę. Zrób trigger na 200.
This resonance. Okay, and the black line is what is this? This black line there?
Tu jest bliżej, nie do CS-u. Stop stymulacja.
Bartek, this black line, what is this? What's which is crossing this scar area?
Which one?
I think Angie means mitral annulus mark.
It's probably it's a shade of the fan.
Yeah. Bartek, are you also going to ablate in the septal appendage?
No. I was considering isolation of the appendage, but I'm not sure if there's not too much harm for the patient regarding the thrombus formation inside the appendage.
Do you occlude if you isolate the appendage?
The question is, of course, we can isolate it very close to the ostium of the appendage, but then occlude. But what to do if the conduction recur? Then the perfect option is to, I don't know, remove the appendage. I'm not sure. Stymulacja. Stop. Stymulacja. No i szybciej troszkę. 600. Okay, now I'm happy about it.
Yeah,
okay.
very much.
Let's go to this posterior wall, this triangle above the isthmus. It's isolated as well, so let's recheck the veins. Stop stymulację. PA, proszę. Okay. Stymulacja. Pokaż z przodu. I teraz od strony żyły. Okay, so I think we're done in the left atrium now. So maybe I get the last attempt to block the isthmus. AP, proszę.
Do you think that this base and ablate technique might be of some help here? This place which was not, because maybe it's problem of transmurality or what?
For the mitral isthmus?
Yeah.
No, I don't think so. I think the mitral isthmus endocardial is blocked. The SCS fibers that are still conductive. So he needs to go into the CS and block it there. But the CS anatomy is difficult.
We have the answer probably what to do.
Yeah.
Okay. Tomek, poczekaj, wiesz co, zrobimy entrainment z CS. Ponieważ to jest najbardziej prawdopodobne. Tak, spróbuj, zobaczymy, przejdzie. A ile mamy cykl? Co to jest komora, co droga niestety. Czekaj, wypadnie. Nie, inaczej. CS9, weź dorzuć 7-8 swoje, albo z 5-6. 5-6. Okej. Tak. Okej. Pokaż mi review screen. Jak? Okay. Okay, so as you can see, entrainment from the coronary sinus is good. So we have probably to block this.
It looks like.
Well,
Looks like.
Yeah.
Look, when you go to move the map to LAO a little bit more. LAO, more, a little bit more, not too, this is too much. A little back. You see that there are some visit tags which are on the outside of the CS, and then you have some on the inside.
To connect them, right?
Yeah, on the top there, just there, yeah, there. Maybe?
Just go around the wall of the CS, I'll try. Pokaż mi cień CS-u, który mieliśmy wcześniej.
nie, sam
There.
The entrainment is that
Can we see the live electrograms?
Live screen?
Yeah. And yeah. Burn there.
No contact here.
It doesn't matter. In CS you don't feel contact because it's so
25 watów?
yeah.
So you think it's mitral tachycardia? So
Yeah, he entrained the CS and it was good.
So Bartek, if you are not able to achieve termination with in this place, just try to do anterior mitral.
Anterior line,
But then you really bring the appendage into danger to be isolated.
Maybe not, because on the roof you may
for sure.
on the roof you can get activation of the via roof.
Yeah, but if you block Bachmann and you block the classical mitral isthmus, then the appendage is gone. And I mean, you've almost completed this line. There's a little gap, so I would not add excessive ablation somewhere else. I would try to block it here.
But
But we know from MRI that appendage was fibrotic.
We discussed that. Good point. We discussed this, whether he would ablate in there, and he said he doesn't want to because he's afraid of the thromboembolic risk.
Oh no.
I think then you can close the appendage.
If it's isolated with the lines that are away from the ostium, so it's okay, because even if the conduction returning to the appendage, you can isolate it again with these lines. But I was talking about isolating the ostium of the appendage.
Then in this case is didactic that if you just slow down the conduction within the mitral line,
right,
you can have this,
so
you never leave non-isolated mitral line. So do not ablate there, or just ablate until you have the block.
Nightmare isthmus.
Yeah.
A regular nightmare.
Isn't the cycle length prolonging a little bit?
Jak sprawdzisz cykl?
Just a wish.
No. 3 milliseconds.
It tells you that the colleague has been there before himself. And
But that is why we stopped to perform a posterior mitral line at all, only anterior, until I have a feeling and a proof that posterior mitral line is fibrotic, really fibrotic, because then it's easy to isolate.
But you mean from the signals, right? From the voltage?
Yeah. So if voltage map shows you.
Okay.
Oh,
okay.
whoa.
Congrats.
You are a great electrophysiologist.
Thanks. Let's see the block.
This is blocked now.
I hope. PA to proszę, AP. AP i lewy bok poproszę. Stymulacja. Z uszka, tak? Postymulujemy. Że nie, stop. I think it's not blocked, unfortunately. Because, can you see the review screen?
One ablation catheter was really short.
Okay.
But why don't you go there where it terminated and look around there?
You mean
The spot.
again?
Yeah,
Or
go there where it terminated. There, then turn the map. So look for the signals there. Can we see the signals?
Tiny potentials here.
Yeah. Now you could try pace and ablate actually. Pace there and ablate there.
So-
Zablacyjny. Unfortunately, our setup.
No, we don't have.
It captures there, burn there.
Stop.
How much energy do you use?
In CS 25.
Yeah, go to 40.
40.
Yeah.
Okay, do it 35.
Your choice.
Okay.
You're probably not even pointing to the ligament of Marshall. You're a little bit away from the annulus towards the vein, and you're just in front of the ligament of Marshall. And muscle fibers in there can be a problem.
Nie wiem, do połowy się cofam. Stymulacja? It's longer.
Yeah, it's longer. Yes.
So maybe we have block. Let's check it.
Or just burn one more there.
One more here. Okay.
Why not, basically?
Okay.
Raz.
Okay. Stymulacja ablacyjnej. It's still something. I would check for the block. So, poproszę stymulację z PV. It's blocked now. Okay. So probably I'll wait a couple of minutes and we reach the end point of the procedure. So the veins are isolated. The fibrotic area is beside appendage.
Can we have a look on this MRI again, just to see?
Poproszę mapę, zupełnie przezroczystą. Samą przezroczystą zupełnie i rezonans.
Nie ma.
Więc
nie ma kiedy nawet wyjść.
Ale on jest naładowany.
Jak go?
Pokazuje baterię, że jest okej.
Znaczy nie, no właśnie.
To jest jedynka.
Troszkę przezroczysty.
Dlatego on miał być na mównicy, on działa, on jest wyciszony, bo to jest na mównicy.
A to można go podgłośnić?
Można.
I też będzie słychać tam, tak?
Będzie.
Dobra.
Profesor ma tendencję do tego, że on cały czas...
It's really nice for presentation, you know. It looks
No, it was a great case. It still is. We were discussing what should be optimal approach for persistent atrial fibrillation. Should we do such an extensive procedure, or the PVI for first step is enough? What do you think, Chris?
To ten podgłośnimy, dobra?
Well, I'm clearly in favor of substrate-based treatment concepts, and if there's disease, it needs to be treated. What is unclear to me, and what the future will tell us, is whether this kind of imaging is able to delineate the substrate or not. And therefore, I'm curious to see the outcome of DCAF. Until we have that, I think, as a good standard, a substrate description by voltage map is probably a good thing to do. And this is an individualized treatment.
Okay.
Yeah, well, that's only a question which reminds what really shows this MRI image. But it's, of course, it's different question. But anyway, it looks like it was really great case. Will you recheck the PVI isolation, because we have some time?
Or isoprenolol challenge? It was quite extensive ablation, so and we have a post PVI flutter, so maybe it will be worth it just to perform isoprenolol
For some non-PV triggers?
Yeah, for non-PV triggers or recurrence of AET.
So do you think that the isthmus will reconnect after the isoproterenol?
I have no idea, but we have time, so we can do something.
I'm doing it on a regular basis.
We can also sing together.
Okay.
I would just finish the procedure, you know, if it's,
Yes, I would finish
if it's
the
blocked.
procedure now.
One question, Bartek. Where is the esophagus actually?
Well,
Somewhere.
You mean the probe?
Right. I'm just asking. Do you use one or don't you use one?
No, I don't.
Okay.
I just make sure use the lower ablation index in the posterior wall.
Okay.
And try to not to exceed 15 grams. So that's my point.
okay. So Bartek, so do you have to add anything, or because we are about to finish, I see.
Honestly, I'm a little bit exhausted. So
What were you doing last evening?
nothing, unfortunately. No. I need to change it tonight. Okay, the isthmus is still blocked, so I will remove the catheters from left side. Stop stimulation. Okay, I'm really interested in the results of this study, especially in the terms of recurrence or viability of these areas. Will it create some substrate for secondary atrial tachycardias during healing? I don't know, but it's some kind of another step forward, I think, just to find out what's the best approach for persistent IF and some structural atrial disease. Another thing is the comparison of bipolar maps and fibrosis detected in MRI, that it's such a mismatch. So,
well, that may be the case, because these are two different methods. One is imaging and the other one is electrograms. So they measure fundamentally different stories. And it could well be that the MRI will always show something different than the voltage map. That remains to be seen. Yeah? And then the question is, what is more important to be treated? And I think these are open questions, and therefore the study is important.
But still, if you have fibrosis, you should have some lower voltage area there.
Well,
If you have extensive fibrosis at that point.
At one point, yeah, when you have a scar, you see LGE and you see low voltage, but everything in between is not black and white, and we have no good histological idea how much fibrosis reduces voltage by how much. We just don't know.
I still think that there should be some correlation. So I presume that this is not going to work.
We will see.
No, therefore we have, well, the study is done, and well, at least the end point was reached, and we have what we have planned. Well, how far those fibrotic or the green area will correspond to what you, well, expect with amplitude of or fragmentation. We'll see. Perhaps you will tell us.
No, I can't. I think we have to be humble enough to say even the voltage map, the voltage reduction, we don't know, and how much it correlates to actual fibrosis. We even the voltage cutoffs that we use are unclear to some extent. They are just extrapolation from the ventricles. And for both methods, for the MR as much as for the voltage map, we need more histological workup in order to understand what they mean.
But still, you can see that, for example, you have some other signs that show you that this is true. For example, if you have low voltage area, usually it can be an isthmus for some tachycardia, or the current can go around this place if you have low voltage area. So you have some other findings that they show you that there is something in that.
Yeah, but how much low voltage is low voltage?
We don't know.
Yeah.
Okay, Bartek. Anyway, congratulations. Can we make some?